The Truman Katz Center for Pediatric Bioethics at Children's Hospital in Seattle presents its second annual conference, Ethical Issues Related to Vaccination of Children. The Truman Katz Center is the nation's first center dedicated solely to the study of research and healthcare for children. During this 5-part television series, national experts discuss vaccine policy, parental rights, and global controversies surrounding childhood vaccinations. In this program, Dr. Lawrence Corey, Professor of Medicine and Laboratory Medicine, Head of the Virology Division at the University of Washington, and Head of the Program in Infectious Diseases at the Fred Hutchinson Cancer Research Center, addresses the importance of developing vaccines for emerging and global infectious diseases, such as AIDS and bird flu, and stresses the need for new research infrastructure.
I'm going to talk to you about something that maybe relates a little bit to the rotavirus, certainly relates to HIV, certainly relates to anything that of us working in global health, is the sort of issues we have and the difficulties we have in the way we approach developing and making vaccines. So I'm going to really talk a little bit of science, but more policy, and how one tries to take scientific promise into public health, and in the field of vaccines, where there's just an enormous disparity between what society wants versus how we're developing things. And this is not an anti-capitalism talk, because I am a capitalist, but I think that actually, and I'm not here to bash pharmaceutical companies, I'm actually more bashing the own organizations that I come from, which is academia, as to what its roles and its responsibilities are, and what the research medical establishment of the developing world needs to do and should do. So we'll start from there and just sort of say that I think earlier in the day you've heard that vaccines are the greatest cost-saving technology of almost any healthcare intervention, and we can talk about measles, mumps, rubella, polio, smallpox. It's wiped out a whole series of diseases, but yet the concept of developing a vaccine for global health, let's say where I spend an enormous amount of my time in developing an HIV vaccine, which I think almost every health minister and every politician in the world would want to happen, but yet, we haven't done that. Now, we haven't done that for a variety of reasons, and I'm going to spend a little bit of time on that. Some of it is certainly scientific issues, and it's a formidable issue. But it's not just all science, it's how science gets done. And maybe I'm going to spend most of the time talking about the pandemic flu. Because here's something which we have a vaccine, but yet we at the moment have sort of chaos as we think about developing better technologies and newer technologies for pandemic flu. So first, to say that the list of microbial pathogens wreaking havoc on human populations is large. And the American Society of Microbiology just issued a report on candidates for vaccine development, and I'm not here to give you microbiology 101. But you can take the most significant human health problems in the US and abroad, and that can be HIV and genital herpes. You can do the sexually transmitted diseases. We have HIV. I guess I made this slide a couple months ago, so human papillomavirus, I guess, we could say yes, but, rather than soon, but, it's only a couple weeks. But syphilis, chlamydia, gonorrhea, hepatitis B, we certainly have one. The respiratory agents, if you look at them, we have a few, but their ability to be distributed globally. And we have some enormous numbers of pathogens in which there are, shall we say, opportunities. You've heard a little bit of enteric disease with rotavirus, but we're right by the cruise ships, so norovirus, it's warm. I wouldn't get on that cruise ship anymore, unless you want to vomit. But, you know, salmonella, especially more and more drug-resistant salmonella, cholera, we do have effective vaccines, many of the E. coli's. Vector-borne diseases, obviously dengue and malaria. We do have a couple for Japanese encephalitis and yellow fever, but again, enormous number of leishmania, an enormous need in the developing world, as is schistosomiasis. And then there's the bioterrorism issues, and you can go through that. So the implications of this is you would expect a thriving scientific enterprise in vaccine research and development with all this opportunity, shall we say. But the vaccine field as a whole, whether for new vaccines or for vaccines that are currently in use but could use improvement in efficacy, safety, or deliverability, is really sick, and because we have let this be driven from a traditional pharmaceutical way, which is to leave it to the commercial sector to actually develop and design vaccines. And the reason of that is that there is an incredible imbalance between societal value and private sector economic value for vaccines. The societal valuation is that it's a great cost-saving technology and has great societal benefit. But we treat vaccines as a commodity. Developing a vaccine, I'll show you the next sort of slide. Most of the males above 40 in the audience, or 45 in the audience, are on this drug to the left, Lipitor. And Lipitor gives you a 50% reduction in your LDLs and about a 20 to 25% reduction in myocardial infarction. It has a maybe say 10% discontinuation rate, about a 10% side effect rate, and 50% of the people require monitoring. Its clinical development cost was about $500 million. It costs, even with prepayments, the drug company is getting capitalized at about $2,200 a year for 20 years. And it's actually cheap to make. And its market in the United States alone is $7 billion. Now, I can take a vaccine, and if it had a 50% reduction in disease, I'd be calling that, people would say that's schlock. At a 20 or 30% infection side effect rate, and I had to draw blood to monitor anybody, everybody would be horrified. It actually probably costs more to develop a vaccine, so it's a higher bar, more to develop. Look at the, Merck is, here's a 100% effective vaccine to prevent cervical cancer, and people are just moribund that it's $120 a dose, or it's going to be $360. Are really yelling about the fact that, we might not be able to do this for $360 to prevent cervical cancer. Its manufacturing costs are a hell of a lot higher, let me tell you, than making a pill that you can crush and put it into a tablet. And if you take all vaccines throughout the entire world, their total market value is equal to Lipitor. So if you're sitting in a boardroom of a commercial company and saying, gee whiz, where should we put our resources? We have a higher risk. We have a higher liability. If we make it, people want it as a commodity. What are we going to sell? So this imbalance, of saying it has high manufacturing costs, high liability, the lowest profit margin, the highest hurdle of effectiveness, and the highest hurdle for safety. So why should, the reality is that what we want versus what companies will put as their highest priority are way out of whack. Now, that doesn't mean they won't play in the sandbox, and that doesn't mean that the commercial sector will not, cannot be found to be an important part of vaccine design and development. But it does explain why there's very little movement at times in the field. It actually does explain, this whole issue with the rotavirus and rotazyme. You can yell, but if you're sitting there with a liability point of view and you're a large company and have a large liability, what are you going to do? What are the decisions going to be made? So we just need to understand where we're coming from, is that what we would like from the public health point of view, what we would like from a societal benefit point of view, versus the structure we have made to actually develop, design, and make the decision making are really out of whack. So how do we sort of put it in balance? So is it possible to restructure this mismatch in the value systems and the economic incentives? And so I'm going to use influenza virus as a case study. So we were all aware of the problem with influenza last year when Chiron's plant, which of course, which was not in the United States, which was in England, and there are very few production capacity plants of making vaccines in the United States, went out of business. And the issue is, will we have enough influenza vaccine? So what is the issue with influenza? So here's Microbiology 101. It's a virus that lands by a protein called its hemagglutinin, and it releases from its cell by another protein called the neuraminidase, and has a bunch of other genes in between. And it's able to antigenically change its landing gear. So the surface of essentially the outer counters of the virus and the clothes it wears changes enough so that the immune response doesn't recognize it as avidly as before. And it can do that in multiple ways. One of them is a point mutation. We call that antigenic drift. The other way is to actually have a genetic reassortment, which usually occurs when an animal virus, an animal influenza virus, and a human influenza virus co-infect the same person, at which time one can get genetic recombination and one gets what is called an antigenic shift. And we'll come back to that when we talk about bird flu. Now, influenza is in and of itself a significant disease. About 500,000 excess deaths globally per year. This is a slide, actually, it's a poignant slide to me because I actually just showed it to my son a couple days ago because he's an intern at Duke University, so he's worried about killing people. And I showed it to say that excess deaths, I had to calm him down. He was on the pulmonary transplant service, and he was saying, "My God, what am I doing here?" But anyway, I won't digress too much. But really, there's a pretty constancy to death rates, certainly in our country. And they actually go above the norm. Only two epidemic situations cause that. One of them is influenza, and the other one is heat waves in St. Louis. Now, heat waves in St. Louis we don't have to worry about in Seattle, and we can avoid by just not living there. There can also be heat waves in Chicago. It's basically heat waves in the Midwest. But influenza is a disease that is the only disease that actually changes the sort of the normal pattern of death that occurs in the United States. And it accounts for a significant amount of hospitalizations, a significant amount of economic costs. Yet, despite this economic and clinical burden, vaccination guidelines for influenza vaccine have never been commensurate with the morbidity that has occurred. The utilization of the vaccine has been quite variable from year to year, and the production costs have increased, and the regulatory requirements to become more stringent for vaccines using a 1950s technology. And this actually shows this. If you actually look at the United States and look at the vaccination, people over 55 who have chronic disease, et cetera, we should be using anywhere between 100 and 200 million doses a year. Now that we're thinking about using it for children, that would go up even more. But yet, look at the variability here in the doses produced and the doses distributed. In 2002, they made 95 million doses of vaccine, but distributed only 83 million. You threw away 12 million doses. So again, commercial companies look at this and they sort of say, well, you want me to build a plant that's going to cost me $400 million to $500 million. You want me to make a vaccine that you want to buy for about $1 or $1.25. And I've already just shown you, just 2 or 3 years ago, I made the stuff, and you threw away 12 million doses. Well, are you going to guarantee me that you're actually going to make this? And so, you see these news conferences with all the manufacturers in there, and George W. Bush telling them that we need to increase our vaccine manufacturing issues, but you then look at what the economic realities are. And do you think that that is actually going to happen? No. No one would sit there and spend $500 million making a plant to produce something that you're going to sell for $1. So this issue is how is this going to be solved? And that requires rethinking the issues of either the regulatory issues, the subsidization. I'm not saying, or be drastic, sort of say that some nonprofit, public-private, or some nonprofit enterprise need to be essentially brought in to actually do this. Now, it's very clear that industry has the expertise in order to do this, and the regulatory hurdles and the expertise to make vaccines is not trivial. But again, it has to be commensurate with our capitalistic market. So pandemic influenza is bringing these issues to the forefront. And here's an interesting issue. I'm not here to say I know when pandemic influenza is going to occur. I really do believe that eventually we will see pandemic influenza emerge. And I think what we're seeing here is very analogous to what we saw with HIV, and what we now learn about HIV is that a virus that started its first sort of introduction into the human population in around the 1920s to the 1930s, and required multiple introductions in the population to occur. For pandemic flu, what you have here is us recognizing that H5N1 occasionally is being introduced, again, because of the symbiosis between humans and chickens, and well, the high density of chickens and the close proximity between humans and poultry in the world. So you're seeing its introduction. Now, even though everybody is concerned about the high mortality rate of pandemic influenza, to me at the moment that's what's saving us from pandemic flu being spread. If you think about it, it's usually not in the virus's best interest to kill everybody quickly. And even though there are movies about Ebola and Marburg and the viruses that have 80 or 90% mortality, you see localized outbreaks, but you do not see these viruses widespread throughout a community. And the reason is that if you die quickly, you can't transmit it. So to some extent, that is actually what's happening with the introductions of pandemic or H5N1 virus at the moment. It has very high pathogenicity in humans, let's say 70–80% mortality. If you look at most efficient flu, that seasonal flu has a mortality of 0.1%. As I'll show you later, if you actually look at the 1918 strain, it had a mortality of about 5 to 6%. So if we see a virus that gets adapted to the human population that actually has a lower mortality, which means more people survive it for a longer period of time, and therefore it's shed more asymptomatic carriers, more shedding, more spread, more introduction, that is when we have to be really worried. When we get a genetic mutation in which the mortality occurs. And if you look at that in the 1918 epidemic, the number of deaths are truly astounding, 20 to 40 million. If you extrapolate that to the current population of the world, it would be 200 to 500 million deaths, just to put it in perspective. Let's, and these are just sort of, this is actually a picture from Seattle during 1918. I think this is sort of pretty vivid with respect to sort of cataloging the deaths during the October, November, December, and January, and then seeing the end of the epidemic in February by just looking at, this is actually from Philadelphia, the death certificates kept in books. Now, I think most of you are aware that most influenza is associated with sort of what people tend to call a U-shaped curve, which is the very young and the relatively old. I don't no longer say the very old when the curve starts ticking up at 55. But with pandemic influenza, it was also very high mortality rates in the 20 to 35-year-old population. And just to give you some sense of doomsday kinds of things, these are figures that people pop out of books, and I don't really want to talk to about that at the moment. But why we're concerned is that actually when I first worked in influenza, it was felt that most genetic recombination that would occur would actually occur from pigs. And it went from sort of swine to pigs, pigs to, and humans coexisted, and then you got the genetic recombination between pigs and humans, and that's how you occurred. And actually the cloning of the 1918 virus, in which they went and got the bodies out of the permafrost and able to then resurrect the virus from those people who died in 1918, and clearly showed that it derived from an avian strain. Now that led to this concern, and let all of us work in this field concern, because the contact between human poultry, or not human, they're not human poultry, between humans and poultry is, enormously different than between humans and swine. The densities of chickens in East Asia and Asia per se is just enormous, and I think I took out of the talk some map that someone actually does densities of chicken per whatever. I didn't realize that someone actually did that, but the poultry industry is actually pretty huge, and you can see that the ability to ever stop that is just not possible. So the issue of how to prevent that exposure and how to therefore prevent these introductions becomes, in my opinion, actually quite problematic. Now, there has been a lot of concern about migratory birds as a major vector. And again, my knowledge prior to bird flu coming up of migratory bird flyways in the world was actually only second to my interest, which was nil. But I actually now have a slide in my talk here of the migratory bird flyways, and you can see that Seattle is over the flyways, and you just have to look at all the geese that are all over our place to say that, hey, we got those things. So again, the ability to prevent the migration of birds is nil, and the ability to control this. Now, it turns out, actually, at the moment that I guess I'd just be more lumper, think of it a little bit more like rabies, that contact between humans and wild birds is not nearly the extent between humans and domestic poultry. And so for the real sort of, to me, contact point between humans really will be much more in the domestic poultry business. And it's preventing that transmission between domestic poultry and humans that is probably going to need to be the point of contact that we will need to make in preventing the epidemic. So the prerequisites for a pandemic are that a novel subtype emerges and becomes endemic in animal populations. That's actually already occurred with bird flu. There's a confirmed ability to replicate in humans and cause serious illness. That actually has already occurred also in humans. There's a high level of susceptibility in human population. None of us who are in this room or elsewhere have H5N1 immunity. And there's evidence of efficient transmission from human to human, and that is what currently is not happening. That issue of efficiency is what it occurs. Now, we can look at the number of genetic mutations that are different between the 1918 strain and the strains we have now. And there's about 15. Some people say 12, some people say 18, somewhere between 10, 12, 14, Some people say that's a large number, some people say that's a small number. The point is even if you look at the number of genetic mutations, actually if you count that number, you know that eventually we will be able to reproduce that, with the high rate of replication that occurs in the contacts that occur between humans and poultry, and the high rate of infectivity, the likelihood of transmission. Now, the real issue is just because you make something that's genetic, will that have the same pathogenicity? And that remains to be seen. That's something that we actually cannot predict. But I think you have to look at this to say that there are going to continue to be multiple introductions, that multiple introductions provides the host and the virus to undergo the adaptation to the human system and to the human body that allows it to be transmitted, and that I think that we have to be concerned about it. So how do we prepare about it? And there's lots of reports that the government has, that George W. Bush has put out, and he's actually throwing a lot of money at this. The issue is, where are we spending our money, and are we spending it smartly? And here's where the issue between policy and science interact, and what would you do and what need you do? Now, everybody's talking about stockpiling vaccines and taking our current mechanism of making vaccines, which requires chicken eggs, which of course, if the poultry are sick, is problematic in of itself, whether you could get enough chicken eggs. The people who actually make vaccines, the companies, actually own their own chicken flocks to provide the eggs. Now, this is an antiquated technology. There's actually no reason that we're making the vaccine like this, and that was invented in the 1950s. It's 50 years old, that we're still making it by this. There's no scientific reason we should be making it this way. Now, there's a regulatory reason why we make it that way, and I just explained why no one wants to go through the process of relicensing a vaccine and redoing it a vaccine because of the cost that's involved versus the economic benefit. But if you look at what's going on now at the moment is that the H5N1 vaccine actually requires 90 micrograms. The current vaccines are 30 micrograms, so it actually between 30 and 45. So it actually requires an enormous amount of vaccine in order to look at it. The stockpile at the moment is only for 4.3 million people. Our strategy is that in a couple years we should be able to get 20 million courses. And then the influenza strategy from the administration is that we're going to create the capacity to manufacture 300 million courses of vaccine within 6 months of pandemic outbreak. And that is a joke to actually write that down and think it's ever going to be occur. No way. There's behind the lines recognition that you can write this down, that we need to think about how to come up with a way of doing that. So the one way of doing that is to take the vaccine that you currently make and make it more efficiently. And there are ways of doing that in cell culture, which increase the yield, increases the ability to make that vaccine. And a whole series of fair amount of money has just been given to companies that are currently to make the same vaccine that we now use, but to do it in cell culture. So I actually think that if we have a couple years, 2 to 3 years from now, we will actually have a licensable vaccine to make in cell culture. Now, whether we will actually then have the inducements to actually get it out there for seasonal flu, or are we going to just stockpile it, is an interesting issue, and I don't think anybody has dealt with that. So one of the reasons is that the approach requires alteration in the regulatory landscape as well. And here, life becomes more gray rather than black and white. Now, I've talked very much in my tone that I'm a believer in the cell culture approach, and I am, because I think that's the only way to get vaccines out there. But I also have to say that let's go back and revisit the swine influenza issue. So here's a situation in which President Ford, we had this issue when we thought that swine were the real problem, that in 1974-75, when we isolated swine influenza from a few military recruits and occasional civilian outbreak, we went and decided that we were worried about 1918 pandemic flu. We took the vaccine that was currently made in eggs and did the same technology and started a mass vaccination program of the general population. And what happened were two very unfortunate things. Maybe one maybe only one unfortunate thing. Maybe the first unfortunate thing was that we never had an epidemic. But the other unfortunate thing is that the vaccine ended up causing this uncommon disease called Guillain-Barré syndrome, which was really severe and caused the paralysis. Actually, other influenza vaccines subsequently manufactured in the same way don't often cause that. We have no idea why this vaccine actually caused this. So you had a situation in which people think about it and call it the swine flu debacle, which is you made a vaccine, you gave it to a population, you caused some harm, and an epidemic never came. And so how do we handle that? So what happens now if you take a new technology, you think you've made it the best way you possibly can? There was nothing wrong with the swine influenza vaccine. It passed all the regulatory hurdles. It passed all the phase 1-2 testing. It was, made the same ways, just like New Blue Cheer. The only thing we did was change the virus type the same way the virus type has changed and been changed for the last 25 or 30 years. And there's been never any explanation why this occurred. So what happens with the cell culture-based vaccine, if something unpredictable occurs? And what is pulling the trigger of that? Are we going to pull the trigger and sort of say, okay, we think there are a few more cases. Are we going to go in there and mass vaccinate the entire United States population? And what if it doesn't come? What will happen? So there is, here is the policy issues in solving these issues, and what happens when you do this. So I don't have an answer for it. I'm just giving you the policy dilemmas, and they're real, and I think that they're worth discussing. So that's flu. I think the reality is even worse for developing new vaccines, because at least with flu, you actually know you have it's the vaccine that is sort of almost the easiest to develop a novel marker. There's what we call a correlate. If you make an antibody level greater than 1 to 40, you make high neutralizing antibodies. You do this in humans in a phase 1 trial. You actually almost know that the vaccine is going to work, and the FDA actually will license the vaccine based on that surrogate marker. I mean, you have a novel approach. You've got to do a couple clinical trials, but that's very different than breaking new ground with a new approach, like with HIV, where there are lack of correlates of immunity, there are imperfect animal models, there are manufacturing challenges, et cetera. And even in HIV, where you would think everybody in the world would want to make an HIV vaccine, there is actually only one company in the world that is spending more than $15 million on, or actually is involved in making an HIV vaccine by itself, and that's Merck. There, only one company. Every other company that says they're working on HIV vaccines is actually getting paid by the U.S. government, actually to make an HIV, to support their program. Now that means they're using their infrastructure. But the reason is that there are multiple commercial failures. There's high manufacturing costs. There's high liability. If you make it, you're really not going to make any money on it because of the tiered pricing. And there's no assurance that you will get a platform technology on it. And in my opinion, actually, there's no push or pull mechanism that will effectively provide the resources for the private sector to devote a full-scale assault on HIV vaccines. And if you're not going to do it for HIV, what are you going to do it for? As I said here on the left side, even the CIA wants us to develop an HIV vaccine, but the issues of how are we going to do it. So there was a recognition that, and so between when Margaret Heckler, I was there in 1984 to probably the mid-1990s, we were essentially leading HIV vaccine along to sort of say, well, you know, we need this, we know that people will do this, and we'll want them to do this. And, you know, we look back 10, 15 years and sort of say, hey, it didn't get done. So in the late 1990s, the NIH realized that public funding is needed to develop an HIV vaccine, and they did what, you know, economists call the classic push mechanisms. They put out grants to pharmaceutical companies to make an HIV vaccine. You can, you know, it's been good to be in the HIV vaccine field. It's been nice to see this bar go up, and we're getting a fair amount of money in Seattle to work in this arena. But yet, I have to say to you that funding has increased, but we haven't really changed the structure. Money does not solve everything. The initial efforts were largely confined to old technologies. Government funding was still limited. If you actually look at how most companies make a vaccine, they put together a team of people. It's 40 or 50 people. The costs are very high, probably around $15 to $20 million a year for an extended period of time, and you have a full-scale effort working on that. The NIH as a research institution was just not able, and that able means it's that the peer review groups, including the academics, are just not able to sit down and give $20 million to somebody per year for 4 or 5 years. It's just not conceptually possible for the scale. Is just not conceptually possible when you're sitting there saying most of you get a $150,000 grant or $200,000 grant. You know, this is just too much of a scale to think about. And also, giving it to companies didn't turn out to be, even at $4 or $5 million, wasn't exactly efficient because they had their parochial intellectual property concerns, and we're always trying to fit their technologies into a use rather than trying to use all the available technologies to solve a biological problem. And I think that also has been an issue. So in about 2002, a bunch of us who were looking at this started a dialogue on how to alter the current approach. So again, I think that the basis of my lecture here is that the research institutions here are partly to blame in that we recognize that we really needed to reorganize ourselves in a real different way. That if industry wasn't going to do it, who else should step up in doing it? Now the problem we have is in academia is that, you know, we're like stockbrokers. First of all, we'll take money from anybody. And number two is we're currently told to diversify our portfolio right away. Because, you know, if you have one idea and it doesn't work, you know, you're sort of screwed. And so you work 20% on this and 20% on that and 20% on this, and the efficiency of where you work on each of your programs is really a function of how successful you are. But that's not the way to make a product. So we had a problem again about how to develop a model. How do you develop a model to actually bring this together? There were huge bottlenecks in the current system. There was not enough money to do the experiments that were required and make the reagents. Too many part-time people, too few resources to make the kinds of immunogens that were needed, not enough input from academia, and not enough use of what manufacturing and the private sector brings, which is teams of people with expertise to actually make a product. So a lot of us got together and said, hey, we need to sort of change this. And we called it the vaccine enterprise. This idea actually went up to the White House, and these guys on Sea Island actually endorsed it and actually gave some money, including this guy over here on the right. So the G8 actually knows about this. And the Gates Foundation has stepped up to the plate, and in the next month or so, they're going to announce a group of 12 or 13 new programs. Actually, they're in town now, and that's why I wasn't here this morning, was being involved with this, of a series of vaccine centers that are doing this. But the point here is that what you have here is some funding for public-private partnerships at a scale that allows novel ideas to be brought through. So one of the points I would make is that the research institutions of the United States and the developing world need to think about their role in society, and is their role just to publish papers? Is their role just to publish ideas, tell people about the ideas, and then assume that these ideas will be picked up by the commercial sector? Well, in vaccines, it's not. And we need to think through the issue of how to merge the best ideas from academia with the commercial expertise that occurs. I'm not naive to say that Children's Hospital, the University of Washington, the Hutchinson could actually be a vaccine company. I'm not suggesting that that's the case. But I do suggest the case that the researchers who work in this area need to think about that their responsibilities are not just to publish a paper. That a group of, maybe not at an individual level, but on an institutional level, that one needs to think about involving and engaging a culture shift that we start to reward development. And that, that the deductive incremental steps required to make products, whether in my situation vaccines or new therapeutics, should be brought and rewarded within our institutions more than they currently are. So we certainly are. We ended up calling this the enterprise, maybe because we thought it was a starry idea. With HIV, it's an interesting lead whether we can pull this off. There's certainly lots of discussions within both the Seattle and the state of Washington to see if we can take our biomedical research establishments and make them a little bit more product-oriented. There really are active discussions about this to work on that. So my point here is to not to proselytize a little bit about that, but to introduce the policy situations that there is an imbalance between the societal needs and the private sector capitalism. Requires rethinking some of the traditional cut points between the university's role of research and training and that of industry. I've already said what I think are the moral obligations that we have. There is this thing called Pasteur's quadrant that people have talked about, the relationships between the university and industry, which for pure basic research, the university does much and industry does little. Use-inspired research has been sort of the traditional model in which it's some of it's the university and some of it's industry. Applied research has always been sort of industry and the university. And of course, global health, prior to the Gates Foundation, never had anything. Now, between Buffett and the Gates Foundation, we maybe should think about that circle getting a little bit bigger. But essentially was ignored by everybody. And I think certainly from vaccines, we need to actually rethink what this is. And the size of the right quadrant needs to markedly increase. So our hope is that we in the biomedical community in Seattle will alter the current landscape. So my point here is just to raise some questions and initiate some discussion on this area and take any questions that you have.
Following his presentation, Dr. Corey answered questions from conference participants.
So the question is why don't we just take a current H5N1 isolate and add it to a current vaccine and start vaccinating? Not irrational from a biological priming point of view, because personally I think the goal of vaccination should not necessarily prevent infection, but should actually prevent death. And I think priming in some way is better than non-priming to elicit an anamnestic response, even if it is not to the circulating strain. I mean, there's a little bit of Russian roulette to say that if it's 4 years, 5 years, or 6 years from now that we have the strain, and it's significantly different than the current strain, that you will not get enough cross-protection to actually prevent infection. But there have been very few large-scale epidemiological studies that would suggest that how much antigenic shift or drift do you need to prevent mortality. So I think you are positing something that sounds biologically plausible. Now, that raises the issue of, number one is, well, what happens if it's 10 years from now, and therefore A, irrelevant. B, what happens if that component actually has a side effect that occurs similar to the swine influenza and increases the risk that would not be picked up even in small clinical trials. So there's the risk-benefit issue here, and that requires some significant sort of scientific consensus and/or leadership to change that. Certainly, if a company was going to do that, they would want to have liability protection. If you talk about liability protection for corporate America at the moment, and there's one side of the aisle that actually would not allow that to happen at this point in time. That raises a lot of antibodies. And so the political process of indemnifying that is actually quite challenging, let's say, at the moment in the current environment. And I don't think you'd actually probably get scientific consensus on it yet at this point in time either. So, it's a reasonable idea, but the politics and maybe even the mathematics of developing the consensus of it are difficult. Now, the other hidden belly here is that, we're talking about influenza vaccine that's used in the United States, Western Europe, and Japan. And no one else, if you ask someone in Africa, do they get influenza vaccine? It's like, huh, what's that? And so the developing world, the southern hemisphere, which has a huge amount of influenza, is not part of this dialogue. These technologies are not useful. So the behind-the-scenes issue is we're also not actually dealing with this in a global way. Is it possible to actually make a universal influenza vaccine that would cover almost all serotypes and prevent the death? I actually think it's not that difficult. I think I could say for sure the answer to me is yes. There are all sorts of vectors that could be used to drop these genes in to give universal priming, that you could get influenza as a boost, and I think you would probably be able to be protected against death. In fact, I think there's some evidence that a lot of experimental evidence to suggest you could do this. So I actually think that the tools that we have are not going to be very effective in even in the industrialized world, and the current tools are basically, you don't hear the dialogue about how about the rest of the world. And the reality is we don't want to talk about that dialogue because, you know what? The policy couldn't work. I mean, do you think you could actually immunize most of the people, let alone within a 6 or 9 month period of time from identifying a pandemic to actually get this to the Africa, let alone most of Asia? No. Let alone get it manufactured, delivered, out there? No way. I would maintain that what you need to do is actually think through the scenarios and start developing vaccines, probably for seasonal flu, that could be rapidly modified to handle pandemic flu. There are, again, vectors that can be used that really grow in high titers, that actually, once you drop a gene into being making 600 million or 900 million doses is actually very doable. And if so I think that the real issue is in my opinion, is that there needs to be a lot more work and development and discussion about technologies that actually will solve the problem. Because I'm not sure if I was sitting in that place that I wouldn't do what everybody else is doing, which is, we're going to stockpile Tamiflu and we're going to stockpile our current vaccine and make everybody feel like we're doing something warm and fuzzy. But there has to be some real discussion about the holes in that strategy, which are huge, and the investment that needs to be put in to actually try and solve the strategy. It's sort of, I haven't framed this talk in the issue of personal ethics, because most of the time we deal with ethics, we really put upon it in a very personal way. But I think there's the ethics of leadership. There's the morality of our own society, and Europe also. It's not just the United States here. It's all of Europe and Japan. The G8 guys over there. To actually say the strategies we're pursuing for our population are really not relevant to the populations of the rest of the world, and what are our obligations to try and put money in to help solve that. And that's where I would say that I think the discussion has been frightfully immature. I think the ideal point I would make in this whole paradigm is not to exclude industry, is to say that what's going to happen is design and development should be much more into the public university research structures. And once you can demonstrate that this vaccine or this approach is going to work, I think industry will come in and do it. Now, there'll need to be some decision as to, if you had a Leishmania vaccine, that someone's going to go ahead and actually, buy it and use it and distribute it. But I think the Gates Foundation and now the other foundations are starting to move forward and saying, okay, they'll do that. So once you have a defined market, I think you can then do some business development and people will step in. And if it's not people in Europe or in the United States, then it's going to be India or China. I mean, both of those countries have conscious efforts to say that I am going to be the source of biomedical and biotechnical manufacturing and development and sales for the rest of the world. I mean, that's a conscious strategy. Yeah, China's not interested in us working with us really on HIV vaccines. They're going to just do it themselves. And when they're ready to do it, they will do it. They will make it and look at it and deal with it. So that's a conscious strategy, and you just need to recognize that. So therefore, I look at this saying, it will get solved. I am very confident it will get solved. I'm not sure it's going to get solved by any American corporation. But if they know how to make it, you can tell them how to do this, and you've defined that it will work, someone will step in and do it in this global economy. Even though people profess that the regulatory issues are, quote, easier outside the U.S., they're not, actually. The standards are high, and the standards have gone up, and this conference is an illustration of to many expense of the issues that go on in doing clinical research and the costs and the expense that go with that. And those are the realities of our society, and I'm not sure that they are going to. In fact, I'm pretty confident in the next 10 years they're not going to change. But the costs, but they have upped the ante of the costs. I mean, I will just be frank with everybody that, I think the amount of, been in the business of doing clinical research for a long time, and we spend probably 40 times more for clinical research in 2006, an A study, than we did in 1986. And that's just, and it's not with, and it relates to the standards that are required. I'm not saying that they're, and don't construe that I think that this is wrong. I think we do much better work in some areas. And in some areas, you can say, well, maybe we could economize and deal with it in different ways. But I'm not sure we'd save that much money as it relates to things. So. I think the standards are high, and they probably should be high. And I'm not sure they're going to change much. All right, thank you. And
you have been watching a session from the 2006 Pediatric Bioethics Conference, Ethical Issues Related to Vaccination of Children, presented by the Truman Katz Center for Pediatric Bioethics at Children's Hospital in Seattle. For more information about immunizations, please visit the websites listed here or go to seattlechildrens.org/bioethics. The Childhood Immunization Schedule, www.cdc.gov. The Immunization Action Coalition, www.immunize.org. The Influenza homepage, www.cdc.gov/flu.